Julie has her own private practice. She's the owner of Treasure Valley Endocrinology, which has been serving the Treasure Valley for 30 years. So congratulations on that. She has experience managing pituitary and thyroid disorders, osteoporosis, and extensive experience with diabetes. And as you may have guessed now, she's a close friend of Dr. Bullmeyer, who spoke yesterday. In addition to her clinical practice, she enjoys spending time hiking with her dogs and playing piano. And we should point out that Dr. Foote also served as the ACMS board president in 1998 and 1999. Today, she will provide us with an update on diabetes. Welcome, Dr. Foote.
Thank you very much. I really appreciate being invited here to speak to you, and I've missed the winter clinics so many times in the last several years. I've really enjoyed it. So I'm going to speak to you today and give a diabetes update, which feels like drinking from the fire hose. But fortunately, I was given some clues on what topics to cover, which makes life a little bit easier. So I'm going to confine my comments to type 2 diabetes. I'm happy to, oh, there you go. I'm happy to discuss type 1 at a different time, and we are seeing new patients. So if I can help with any questions either here or by email or in the clinic, I'm happy to do that. So today we're going to cover 4 topics. I'm going to cover the ACE guidelines for use of medications, talk a little bit about GLP-1 receptor agonists. Yesterday, we heard some good news about SGLT2 inhibitors, which makes my life easier today. So I'll cover those a little bit. And then at the end, we'll talk about CGMs, and that's where I'll say a little bit about type 1 only in that section. If you could hold your questions till the end, I'm going to have to talk fast. So I'll try to get through it all. In addition to ACE, the American Diabetes Association publishes guidelines every year in December, and they came out in early January. This is an algorithm and a graphic talking about the comprehensive medical evaluation. And we will be staying in this top from 12 to 3 on talking about assessing key characteristics of your patients and specific factors that they bring to the table that will impact your choice of medications. It's a pretty meaty thing that we do in our clinic visits and in our new patient follow-up appointments to take care of diabetes in a comprehensive fashion, which is difficult and it's a complex disease. So the ACE guidelines in the last 4 years have really focused on assessing diabetic complications in your patients to guide and tailor the medication therapy. And this is part of the algorithm that focuses on complications, the complication-centric approach to their glycemic control. And of course, anything with diet and exercise that can be done, the lifestyle interventions really help your patients. But I do see a lot of patients who have an extreme inability to exercise, so they can't always participate in programs. So the medications are here for them, and the choices of medications are often and becoming more often independent of their glycemic target and independent of any other treatments that they are on. So in a clinic like mine, when patients have been on, say, 4 different kinds of drug for the last 10 years, we are running in place to accommodate the new guidelines and get them on the right medications, and you have to recreate the wheel. And sometimes they don't embrace that very easily, so you have to really focus on the high points. So you assess if your patient has atherosclerotic cardiovascular disease, heart failure, stroke, or chronic kidney disease. And if they're lucky and they don't have any complications, that's where on the right side of this algorithm, you immediately go into a glycemic goal-centered choice of medications. And I want to point out one thing. It's kind of rare in medicine, although we heard about it in hypertension yesterday, to use 2 drugs at the same time right out of the gate. And that is a welcome choice in patients who present with an A1C over 7.5%. It's not something that I'm good at. I'm sort of a purist. I kind of want to do one at a time and then rapidly accelerate the treatment. But the truth is that we maybe should be doing that differently. This is overwhelming. But for those of you who don't feel comfortable or understand or haven't read about all the different profiles of the choices for glycemic therapy, this is it. And we are going to stick in these columns: GLP-1 agonist, briefly touch on dual agonists, and SGLT2 inhibitors. I think that sometimes add-on therapy relies on the DPP-4 inhibitors, because if you look at the green here, they're neutral in a lot of categories. But DPP-4 inhibitors are sort of weak actors, I would say, and they're costly. Yes, they're safe. But I would invite you to reconsider the algorithm of your treatment choices, because DPP-4 inhibitors are notably not first or second. The history now of GLP-1 receptor agonists is interesting, and this is a write-up in Science that was published in September regarding Svetlana Matsov, who was born in Yugoslavia and was an investigator and one of the inventors of GLP-1, who did not initially get credit for a very long time. So it's sort of a fascinating history, and she's being recognized this year as one of the co-inventors of GLP-1. And so you have this very long road to get this class of drugs made, the GLP-1 receptor agonists, that really started in the 70s and 80s. And now in 2005, you have the first GLP-1 receptor agonist that was approved. And then, now we have the world. We have semaglutide in different forms, dulaglutide, liraglutide, and exenatide. And then on the bottom, tirzepatide, which is a dual agonist. That's one of the newer ones. We have a pill. We have more pills coming. We have shots. They're approved for type 2 diabetes. They're approved in weight loss. I don't take care of kids with type 2, but they are FDA approved for use in kids. They have become a little bit of what I call the next drug of abuse. So there were 7 GLP-1 receptor agonists, 2 are off the market, and then the oral semaglutide as Rybelsus was the newest, and it was approved by the FDA in 2019. GLP-1 receptor agonists take advantage of the incretin effect, where in the presence of a glucose load, they help stimulate insulin secretion. And they slow gastric emptying, suppress appetite, and increase satiety, decrease glucagon secretion, delay gastric emptying, and thereby reducing postprandial blood sugar levels, and they also decrease fasting glucose. Eric Topol is a cardiologist that writes online, and I respect his writing very much. He writes in a way that kind of tells a story, and I like that. And he has published, I think in last fall, a review of the GLP-1 receptor agonists. And this is taken from his writing, and it's a composite of all the different studies showing the percentage of weight loss And it can be pretty profound. In the dual receptor agonists, which are over here on the right, you can have 15 to 17% weight loss. And in the GLP-1 receptor agonists, at the low side, 5 to 10% body weight loss. There are double and triple receptor agonists that are being studied and coming on the market. Interestingly, the weight loss in patients with diabetes is less profound than the weight loss in patients with obesity. Of course, the diabetic milieu is complex, and I don't think I understand all the ins and outs of why that would be. But we see that in our clinical practice, that for some patients, it's still a struggle to lose the weight, even with these medications on board. The percentage GLP-1 receptor agonist A1C reduction is usually 1 to 2%. It can be quite rapid within 12 weeks. Sometimes I even see an A1C drop in a shorter time period, but that's usually when you get a meaningful change in your A1C. So that's what we see. GLP-1 receptor agonists, by way of reducing weight, lower blood pressure, and improve glycemic control as well. But now we have broader kidney and cardiovascular protection indications for their use, and I don't pretend to understand their anti-atherosclerotic properties or the anti-inflammatory properties, but they're very interesting work being done in that arena. And they are approved for use for people that have kidney and cardiovascular complications of diabetes. So let's talk about the benefits beyond the A1C. So 3 of the GLP-1 receptor agonists significantly lower the risk of adverse cardiovascular events, or what we call MACE, non-fatal MI, non-fatal stroke, and cardiovascular death. And those are lira, sema, and dulaglutide. In this review, they reviewed 8 trials. This is published in 2021, over 60,000 patients in a meta-analysis. And those improvements in MACE scores occurred independent of GLP-1 choice, whichever one you pick, A1C, presence or absence of cardiovascular disease at the beginning, trial duration, treatment dosing interval, BMI, age, or GFR. Fascinating. So this retrospective review showed a reduction in MACE of 14%, reduction of all-cause mortality by 12%, hospital admission for heart failure by 11%, and composite kidney outcome by 21%, and even a little bit reduced risk of stroke in people who were at high risk. According to the ACE guidelines, if you use the GLP-1 receptor agonists alone, there's no risk of severe hypoglycemia or retinopathy. That gets a little star. I'll show you some information later. There's a little bit of a caution there, and no pancreatic adverse effects. So the guidelines tell us to use GLP-1 receptor agonists in persons with atherosclerotic cardiovascular disease or who are at high risk as first-line therapy, no matter what. No matter the A1C, no matter the metformin, just do it. For an honorable mention regarding retinopathy, if you drop a person's A1C quickly and significantly, say by 2–3%, that's when you can see some reports of increased diabetic retinopathy, and that's poorly understood. That's seen in 2 of the trials. Albiglutide, which I never used, is now off the market, and that had early reports of diabetic retinopathy. And there's a nice review in this article, The Survey of Ophthalmology from December, that speaks to that. Last summer, anesthesiologists provided guidance on what to do with these medications pre-op. And I have to say that seeing this in clinical practice, it's a little bit wiggly and all over the map as to what the instructions are. So they recommended to hold the short-acting GLP-1 receptor agonist the day of the procedure and the long-acting a week prior to the procedure. Well, I have had patients call me and say, I'm having a, elective chole in a month, and they told me to stop. And what do you want me to do? So the guidance is a little bit inconsistent out there. In addition to lowering blood pressure and improving lipids, there is information that GLP-1 receptor agonists improve fatty liver disease. And this is well analyzed in this review by Nivola that was published last year as well. And in the patients with metabolic based fatty liver disease, or formerly known as NASH, these drugs seem to do everything you would want them to do. They reduce the liver enzymes. They decrease the fibrosis scores on biopsy. The patients who had liver biopsy with NASH had improvement. There's less fat in the liver on MRI studies. So it's sort of fascinating. And we started getting patients referred so that we could do the prior authorizations in somebody with prediabetes or simply metabolic fatty liver disease. We started getting those referrals many years ago saying, Julie, you put them on a GLP-1 receptor agonist. We're not going to do the PA. It's very interesting. But you can watch the liver enzymes improve. And so there's a body of information regarding that. I have 2 patients who have died of cirrhosis complications in the last probably 5 years. So it's a real problem. And it's, I guess you could say it's an epidemic. In our post-gastric bypass patients, that's an interesting scenario where some of them get hypoglycemic. And if you put them on a GLP-1 receptor agonist, it slows gastric emptying. And so the thought is that that delivery of nutrients and fast transit after the gastric bypass augments their insulin secretion. And then they become hypoglycemic at hour 2, 3, 4 after that glucose load. And so the GLP-1 receptor agonist can help that. And that was published by Llewellyn and others in 2023. So what are some of the case scenarios? And this is taken off of medical news today, is that face of people who are giving themselves GLP-1 receptor agonist shots, trying to be beautiful. And who knew, that in 2024, sunken cheeks would be thought a mark of beauty. I never would have thought that. So what are the clinical scenarios? Stop the GLP-1 receptor agonist a week before an elective surgery just to be safe. Arrange for alternative treatment if you're going to have that big gap, because I've seen patients raise their blood sugars 150, 200 points. They call me, my sugar's in the 300s. What do you want me to do? And I'm like, well, what happened? Who knew? I recommend an eye exam within 3 months. I don't use GLP-1 receptor agonists very often in people with a history of acute or chronic pancreatitis. I'm very careful. I have had patients beg me to treat them, and I've gone ahead and tried it at low dose for some patients, and it has worked out okay, but I'm pretty cautious. It's contraindicated in MEN2 or medullary thyroid cancer because the GLP-1 receptor agonists increase activity of parafollicular C cells. This was seen in rats. Interestingly, there's a French study that was published last year that also showed an increase in all thyroid cancer, but I think that data has been questioned. So just keep in mind and be careful in your patients who have that rare family history of MEN2 or medullary thyroid cancer. I have several patients who have lost so much weight that you start to wonder if this is the right thing to do. I've taken people off, especially I'm careful in my people who are age 75 plus. I've had people that came in that literally could not eat. They were so anorexic and nauseated. And I think that's a reason to immediately stop the treatment. This is where social determinants of health come into play. I had a gentleman come in and not so stated had a pretty devastating situation in his family, but on digging and questioning, you know, why have you lost 40 pounds? There was definitely food insecurity at play there. And patients won't really tell you that. They'll just, you know, keep taking your drug while they're melting away. So I would say be cautious there too, and ask the right questions. So now we have a shortage. And it's supposed to go through 2024 to the point that in the UK, the National Health Service advised their doctors not to prescribe off-label. It's a National Health Service, you know, not to initiate new prescriptions. I thought that was interesting. There's supposed to be a generic coming this summer. I am not optimistic that that's going to change the price structure. We're not supposed to give off-label information. This special report written by Whitley last summer, if you want to know how to count the clicks, read that article. And if you don't know what I'm talking about, ask me after. So everybody has their own approach. This is a Michigan collaborative on type 2 diabetes on what do you do with patients who are taking their drug and then something happens like a shortage. And I was pleasantly surprised. This is sort of what we do. Patients have to do the homework and they don't like this, but we insist. You have to call the pharmacy. You have to ask the pharmacy which warehouse they use and then call the other pharmacy that uses a different warehouse to see if anybody has them in stockpile. It's a difficult situation, or switch to another one. This is their equivalence chart. It might be an interesting tool. I quibble with this. So before you take that picture, I like mine better. And has to do with equivalent side effects. This is approximately what I do. And I made this at the office because so many people were calling saying, I can't get the what's it, can you switch me to the other? And so, and Mounjaro, whoops, I keep doing that. Mounjaro is the dual agonist, GIP and GLP-1 that gives the best weight loss of all of the GLP drugs that we have on the market now. The Alliance and St. Al's Medical Group came out with a nice guide that I have taken from with permission for prescribers and primary care providers. And this graphic is lifted and this talks about the dreaded donut hole. So in your patients who fall into that donut hole after the initial payment period, they're on the hook probably for $275 to $350 a month to pay for, you know, whichever one they're on. Except for one thing, if you use them in combination, there's a way around this. If you use lixisenatide and liraglutide in combination with the insulin, you can get that for the $35 per month cap. So that's an option. Cost-related non-adherence is a real deal. This is survey data from the National Health Interview Survey up to 2018, and I don't think it's getting any better. And surprisingly, 18% of people aged less than 65 reported non-adherence compared with the older population. And I would argue now that this is worse in the older population than before. Across all age groups, financial hardship from medical bills, lack of insurance, low income, high comorbidity, and female sex were associated with cost-related non-adherence. In the younger set, lack of insurance, duration of diabetes, smoking, hypertension, and high cholesterol increase the odds of non-adherence. And in the elderly, insulin use increase the cost and the odds of non-adherence. In this Optum database that goes through 2020, and they measured it glass half full, the proportion of days covered was 65% in people who were using GLP-1s and 73% who were using SGLT2s, and the co-payment was the thing. So that leads me to switch to the topic of SGLT2 inhibitors. And I'm really bad at dad jokes, although I love them, and I'm not very funny. So you get to look at my German short hair pointer, Juno, and she's hard to catch, I'm telling you. So there you go. So let's talk about SGLT2 inhibitors in type 2 diabetes. They are not approved for use in type 1. So we're back to the algorithm, the complication-centric algorithm. And I want to point out 2 columns. These are especially appropriate in your patients with heart failure and chronic kidney disease. And Dr. Silva did a nice introduction of mechanism of action. They increase glucoseuria. And exciting, they reduce hospitalization for heart failure, reduce symptoms. And interestingly, that's irrespective of the LV ejection fraction. I always try to look at that. I'm forever having my medical assistants try to dig into Epic. We're not Epic users, so we're view only. Can you find me an echo? What's the ejection fraction? It turns out maybe I was making it too hard for myself. They reduce cardiovascular death in people with or without atherosclerotic cardiovascular disease. And according to the guidelines that we're talking about today, they should be used as first-line therapy in heart failure and or chronic kidney disease, irrespective of the A1C goal and irrespective of any other medication. So pick them first, and you will get pushback from insurance on that. There's a MACE benefit with EMPA and CANA, and I'll show you a graphic on possible benefit with the subgroup hemorrhagic stroke. There are medication-specific GFR thresholds. They are hypoglycemic risk neutral when not used in my patients who are on 4 other drugs. The genital yeast infection or genital fungal infection risk is real. And I have seen several patients come to me after visiting the emergency department, and the ER docs pick up on the fact, or you pick up on the fact in your clinic that somebody is unwell and in DKA, even with a modest blood sugar profile. So keep watch for that. We'll talk a little bit about the fracture risk information that was revised and now is a positive. So that's less of a worry. So Dr. Silva showed this slide in a different form, and I think it's easy to get lost when you're trying to look at all the different characteristics of your patient, but GFR is one of the main things to look for. And so we usually live in stage 2 and 3 chronic kidney disease, but for your patients with stage 3 GFR above 30, go for it. I don't use ertugliflozin in my clinical practice. I never tried it. It's pretty restricted in its use. EMPA, you can go all the way down to a GFR of 20 or maybe less in patients that need the cardiovascular and heart failure benefits. The dapagliflozin, it's not recommended for initiation in GFR less than 25 if you look at the guidelines. And this is where yesterday I sort of tipped my hand that sometimes I have nephrologists that I work with who are not in this room, who tell me not to initiate the drug, even if I have a patient that I think might be a candidate. And it's a lot of work for us to recreate the wheel on their medication. And they say no. So I value very much working with nephrology and cardiology in a collaborative fashion in these patients. So I'm always calling saying, hey, your patient has this, that, and the other. Do you want them to be on an SGLT2? The A1C reduction is modest, between 0.5 and 1%. This is a list of the studies that we have. This was published by Lusk in 2016. So it's a little bit older. But you can get lists of all the studies on these two classes of drugs and thousands of patients studied. So look at the GFR. If they have high-grade proteinuria or heart failure, that's a high priority situation. Talk to them about sick days and checking ketones. And perioperative care, we usually stop the SGLT2s a week before an elective surgery. And follow up, this is what I see missed all the time. The GFR lowering effect is about 5 mLs per minute, but it can plateau a little bit, so don't be afraid. Expect about a 30% increase in the serum creatinine. But if you see more than that, think about reassessing their volume status or reducing the diuretics or calling for help. I see patients who have orthostatic hypotension because of their diabetes, and it's exacerbated by these drugs. Dizziness, polyuria are definitely symptoms that you'll see. 4 to 11% of patients have genital yeast infections. I do talk to men about their personal hygiene down there. UTI risk is real, between 6 and 10%. DKA with modest glucose levels. Blood sugar monitoring is extremely important. And interestingly, I have seen several patients come up with hypercalcemia, and that is written about. It's published in some case studies, especially if they're dehydrated on thiazide diuretics. I'm seeing that more and more. So that might pop up in your lab profile. So this is what I would say: begin with caution, continue with caution. I monitor blood sugar, orthostatic blood pressures, kidney function 2 to 6 weeks after initiation, and that might be overly cautious. But honestly, if you say, come back in 4 weeks and check your blood, check a chemistry panel, they'll show up at the next appointment 3 months later. I have a gentleman who was started on DAPA and had a history of acute kidney injury, was on insulin with A1Cs that were completely beautiful. And then in the last year, creatinine 2.6. And then in August, he started losing weight. And I saw him in February. He'd seen nephrology, cardiology, and primary care. And believe it or not, the ball was tossed. Nobody had checked a chemistry panel, and he's not exactly the most diligent patient. And by the time I did the basic metabolic panel, his creatinine was 4.7. So that one bothered me. So be cautious and refer. When you need help, refer. High-grade albuminuria or in the stage 3B patients where you need the help. And their GFR is going down. There was some favorable data in this retrospective review and scientific reports in 2021 that favored in 3 studies the use of SGLT2 inhibitors to prevent hemorrhagic stroke. It's not indicated for that, but I thought that was an interest item, especially since my husband's cousin had an hemorrhagic stroke, probably related to uncontrolled hypertension. Those are the studies that saw that difference. And a special shout out with regard to diabetes and bone. The ADA guidelines have written a section on diabetes and bone. Fractures happen in patients with type 2 diabetes with a T-score of less than or equal to -2. I am seeing more and more orthopedic injuries in my aging patients with type 2. Of course, we all are. Hip fracture risk is increased 1.7 times. Throughout life, it's 40 to 70% higher occurrence than in individuals without diabetes. An 8% increase in fracture risk comes with a 1% rise in A1C. That happens in the blink of an eye. Longer disease duration further elevates fracture risk. The drugs that are culprits are TZDs, insulin, and sulfonylureas. Do a DEXA 5 years into the diagnosis of diabetes or sooner if you think that they've had it undiagnosed. And it's recommended similar to your other screening with DEXA every 2 to 3 years. And I don't use bone turnover markers either. In the original Canvas study, CANA was thought to increase fracture risk. So I use that with caution. And I was not an early adopter of SGLT2 inhibitors, I have to admit. However, since we have more data, the concern about fracture risk with this class of drugs has backed off a little bit. And so this published by Zhao in JAMA shows you the use of the GLP-1 receptor agonists and SGLT2 inhibitors and the cumulative incidence of fractures. And it is not increased compared to this top line up here is the DPP-4 inhibitors. So that feels good. Similarly, in the early days, there was some concern about foot ulcers. And of course, we're very concerned about patients with nephropathy and peripheral neuropathy and foot ulcers. So we're very careful in that frail population anyway. But they had placed a box warning about leg and foot amputations with canagliflozin, and they have lifted that precaution. The donut hole is still a problem. At Cost Plus, we're still talking about canagliflozin, $250 a month, and DAPA, $390 a month for 30 tablets, and that's the baby dose. Another baby picture. That's my one runner who's 11. Okay, so now for the fun part, CGMs. Everybody should have a CGM. Some people who might have had a slightly high A1C might have worn a CGM for a couple of weeks. Yeah, bananas and bagels are bad. So I want to show you the tools that you can use to help yourself, teach yourself about CGMs, because my staff have been with me almost pushing 20 years, some of them. And so they are very good at helping me get CGMs for my patients. So this tool comes from Dana-Tech that is sponsored by the Association of Diabetes Care and Education Specialists. And you can go online and you can say, I want you to tell me the difference between a Dexcom G7 and a Freestyle Libre 3. And you pick and it gives you the printout. You can look up CGM insurance coverage by state and by insurer, and it works. I've tried it. So just for fun on Friday night, okay, let's see what it looks like. G6, G7, tell me about that. G6 works with pumps. They're both covered by Medicare. So this tool will help you compare all the high points that you particularly are interested in. And patients definitely have opinions about these things. So you can tell them to go look at the website. It's not that hard to figure out. This is another tool. The Panther program comes out of Barbara Davis Center for Diabetes. You can go online and you can download these PDFs. I have a patient that has a Dexcom G6. How do I think about that? And their goal at the Panther program is to distill the information for healthcare professionals about these devices. So this tool is very helpful. You can upload information. You can print the information. So it's a pretty meaty process in my office because probably more than half, maybe even 75% of our patients with type 1s are on these devices. We upload their data. We don't have a way in my EMR to import that directly. We print it out, scan it in, and then it's there for the appointment. So you can do that with Dexcom. You can do that with Libre. So here are the tips. Getting CGMs covered depends on what medicine they're on. If they're on insulin, they're in. And their hypoglycemia profile. If they've had 2 events, you can usually get that approved if you write that correctly on the letter of medical necessity or on your chart note. The Libre is the easiest one to get in a short amount of time, but if you have a Medicare patient that has to go through a diabetes supplier, like Advanced Diabetes Supply is the one that we use in our office. Dexcom is preferred by some commercial insurance. So I'll have patients who are on GLP-1 receptor agonists and they come to me and say, I want a Dexcom because my insurance will pay for it. Nobody loves finger sticks. Sometimes a patient can get that quickly as a local pharmacy benefit. And the frequency of the visits, you have to carefully document that you've looked at the blood sugars and that sometimes you have to send those blood sugar logs. And so that's usually every 6 months. The different features are important. Most now are continuous. You don't have to use a finger stick. They have alarms for low or high. Those are customizable. They're compatible with phones. They have different underwater features or water resistant features. Sadly, they are not approved for use with dialysis patients. Ask me after if I do that. Dexcom and Libre are both approved for use in pregnancy, which is a new thing. There are interfering substances, vitamin C, hydroxyurea, and Tylenol in higher doses. And be prepared. This is where my staff are golden. They really help with the letters of medical necessity and prior auths. This is a sample report from the Panther tool. Focus first on what the goal is. The goal is now time and range, not just A1C. And we like to have patients at 70% time and range. With less than 4%, and I would say that even that's generous. I have patients that have 1 to 2% hypoglycemia. So that's the goal for their safety. And this report, you can see their percentage use. I have one patient who came in last week with a personality disorder with type 1 diabetes and an A1C of 13. And she was using her sensor as an adornment, kind of like a piercing. She was wearing it and not looking at it at all. That was sad. You can see the time and range, the variability, the average, and the percentage of low or very low. And then my favorite, you can see the pattern. And this is the common one. They are lower overnight and then they eat and the postprandial blood sugars go high. So it's very helpful. And in that Panther tool that you can download, it will even coach you through how to evaluate hypoglycemia and hyperglycemia so that you can figure out maybe how to tailor the insulin or change the plan. These tools are really helpful in hypoglycemic disorders. I had a patient with a really weird case of hypoglycemia, and she left the hospital with a Libre 3, which was very important for her safety, and she got to leave the hospital. So that was good. Remember that you're measuring with these sensors interstitial fluid. versus capillary blood glucose. So there is going to be a lag between what your finger stick blood sugar is and what the interstitial blood glucose is. That lag frustrates patients, but with the up and down arrows, they can see what their trend is. And you just have to coach them to hang in there, or if they have a low blood sugar reading on their sensor that they don't trust, to confirm it with a capillary blood sugar. So one of the marvels, I think, of my time in medicine, 30 years is a long time to be in clinical practice, but we finally made it. We have the technology. I wish that I could live the next 20 years in clinical practice to see where that goes. But I'm so excited that we finally have these tools that were talked about in theory in the late 80s and early 90s. So I want to thank you for your attention. Hope I did good on the time. I think we have time for questions. And the only thing I would ask as a favor to me is please tell me who you are and try not to present a long case scenario, because I'm happy to help with that offline, but try to keep it general.
Thank you, Gabby.
Mike Bowles, family doctor. What do you use for bridge therapy before surgery?
Well, you know. If they're on insulin, of course, they leverage that. Multiple daily injections increase the basal insulin. If they're on a sulfonylurea or something like repaglinide, I push on that. I've been trying for years to get my patients off those drugs, but they love them. They're cheap. They work. So that's a little bit of a quandary. Nobody loves to go on multiple daily injections of Humalog, Novolog, Lispro, before their knee surgery. They just don't like it. Yeah.
Lynn, endocrine, that was fantastic. Can you tell me where prediabetes fits in?
Yeah, so prediabetes has very similar goals. There is an ACE algorithm for that I can share with you. Very similar goals with regard to blood pressure and lipid management. I'm pretty aggressive with that. I always check the urine albumin status. That's where lifestyle, exercise really are key. And if your patients can't move, then if they're obese, I add the GLP-1 agonist. That's further down on the bottom. If they just can't move the needle and they're going from 5'7" to 6'3", and now you can see that transition even within a year if you're seeing them say for other things, osteoporosis, thyroid cancer. I've seen plenty of people move up in a 2-year period of time while I'm following them. And sometimes it's a hard sell, they don't believe that it's a real problem until you show them the A1C progression, and then they get busy. Interestingly, sometimes I use a Libre sensor because it's the same cost as a copay, to be honest with you. And so they can learn the effect of food. That's off-label, they have to pay cash usually, but sometimes that's a tool that you can use. But there is a guideline on prediabetes in the ACE algorithms that is helpful.
Eric Richardson, Valley Medicine. I had a patient she introduced this to me. What data have you seen on the Brenzavvy, the Bexatil? I don't know some, but Brenzavvy, you heard of that one? At Mark Cuban's online pharmacy selling it for like $47.85 per month to the SGLT2.
Which one is it?
Bexagli, B-E-X-A-G-L-I. So I just heard about it last week.
Is it a combination drug?
No.
It might be a new one that they have.
SGLT2, but
It's
they're marketing it through.
Yeah. Yeah, I haven't used that one personally. I'll have to read on that one, but did they just add it last week?
So July 13th of 23 is this article that I just looked up. So it's been It was approved last year.
When I looked at Cost Plus, those were the only two that I found. I'll have to look at that again.
Yeah.
I don't know. Yeah. Behind you.
Baruch, when, if at all, do you check insulin levels if you're really suspicious about like a pre-diabetic state, but their hemoglobin A1Cs are really not super high yet, but they're super high risk, or they have some complication that you suspect might be related to?
Yeah, usually in that patient population, of course, I'll do the A1C, but I usually do a C-peptide, and there's some guidance on how to use C-peptide for staging. And then you have to be suspicious a little bit, especially in a lean population or people that have a family history of autoimmune diabetes, and check GAD65 antibody. And there's like 5 antibodies that you can check to assess autoimmune diabetes potential. That's a whole different talk on finding the people that are going to progress to type 1. But I don't use insulin levels as often as I use the C-peptide. You have to be a little bit careful about using insulin in young people too. That can be a little higher. So, yeah.
Jenna Lawyer, Family Practice, St. Luke's. Question, what is the incidence of people that you start noticing hypoglycemia that actually develop diabetes because of the hypersecretion or reaction to glucose out of the pancreas?
I don't think I know a number to give you. It's common. I just don't know the magic number. Yeah. Well, you see that sort of as the prelude to diabetes, or they were told in the 70s, 80s, early 90s, oh, I'm hypoglycemic. And then, they're 55 and have gained 50 pounds, and then they're in trouble. Yeah.
Same question. Ann Huntington, internal medicine doc. Thank you so much for your talk. I've done hospital medicine. I love these meds. I've prescribed for 3 years, so these are fantastic. Just a couple of things that we're seeing in the hospital. We've had some folks with kind of delayed gastric emptying from GLP-1s even months after stopping them. So just a heads up for some of the folks, we've had some with Mounjaro and some with some of the others. And sometimes, and even had a medical professional with an NJ2 because she's had such delayed gastric emptying that she's not diabetic. She was on it for weight loss. So we've had some interesting things recently. And then from a SGLT2s, some of those DKAers will have a prolonged DKA.
Mm-hmm.
And so it won't be as kind of your normal type 1. It'll be sometimes even 3 days. It'll last for a little bit longer. And then kind of just a question on the maybe non-diabetics, maybe insulin resistant or obese folks that want to do a CGM. It sounds like it's probably just better for us to start them ourselves, pay out of pocket, because insurance will not cover CGMs unless you're diabetic. Is that correct?
Yeah. So I'm just going to address the third part. So sensors for people who have prediabetes or in your obese but not diabetic population. I have not found with consistency that any insurance will cover that. And so because it's the same as a copay, I have chosen to stop banging my head against the wall. And I just tell them they're going to have to pay cash, period. It's kind of like a copay for a GLP-1 or an SGLT2 inhibitor. And if they gain the knowledge of what lifestyle and food choices are going to do for them, interestingly enough, sometimes 2 weeks is long enough and they remember. Or I have patients that really can't afford that copay, so I'm not being cavalier about that. And they really need a sensor because of other things. So they use it intermittently. They'll use it for 2 weeks every 3 months or something like that as a safety net. So I just choose not to. We have so much paperwork. We have so much to do. We can't get that authorized for everyone. Libre 3, Libre 2. Some of them don't want to use a phone. So there are Libres that still have a reader, you know. The seniors kind of like that because they don't like their smartphones.
I'm Shannon Malabuyo, internal medicine PA. Can you speak into all the compounding pharmacies starting to make GLP-1?
I don't do that. I don't support that. That's not supported by the Endocrine Society. It's risky. It's unregulated. I remember, I'm old enough to remember when people were getting steroid injections of fungus in their spine. I don't do that. That was compounded too. It's completely unregulated. Maybe some of you in here can speak as a counterpoint, but I just don't support compounded GLP-1 receptor agonists. We have enough to do.
Hi, this is Cooper, Family Medicine. I'm increasing my use of continuous glucose monitors, and I have a pretty elderly population. Do you have any educational like websites or how do you educate your patients who aren't so tech savvy and get really confused with smartphones with their readers and in essence use it as just like a glucose monitor occasionally because they can't pull up reports and stuff. Like we've struggled with the time it takes to even get basic use of the CGMs. Any educational resources that you use for your patients?
Well, of course, both your diabetes education clinics that are supported by the hospitals have very good diabetes educators that I've worked with in this town for 30 years, or in that town in Boise. So if patients need extra training, we refer them specifically for that. My medical assistants sit down with patients, we start them on the CGM in the office, and spend a lot of time teaching them how to use either the reader, if that's what they want, or their phone. My MAs put the app on their phone, show them the ropes, invite them to come back in. If they come in because they have a reader and we can't download it with a share code between the two parties, then they come in with a reader and, you know, we just sit there and show them. I think some clinical practices across the country, some of my endocrinologist peers don't have the download, print, upload capability. You know, there are still some independent endocrinology offices that don't have a robust support system. And so some of them are just, you know, looking at the report on the phone or on the reader and showing the patient in real time during the appointment what they're looking at. But it does take a lot of support. And that's why a lot of people still use the reader. Like my brother-in-law still uses a reader. I'm like, dude, you are the god of your phone. Just use your phone. But he doesn't like that. Also, the reader is more discreet. So for people that are in a clean room situation or they're not allowed to have their phone at work, that reader works very well, or it talks to their watch. Okay. Thank you very much.